Good morning, His Excellency Mr. Carlos Vasquez Corrales, ladies and gentlemen. Welcome to the Solidarity Bridge between Singapore and Latin America. I'm Hui Kun, your MC for today. This is the first of a series of 4 webinars to share Singapore's experience with the coronavirus, in short COVID-19, with the Latin American countries. Today's topic is on responding to COVID-19, how an academic infectious disease division mobilized in Singapore. Before we begin, let me run through with you a few house rules. All participants are muted on entry. To interact, please use the Q&A button to send in your questions throughout the session. Participants will be able to upvote to prioritize the questions you want to be answered and comment on others' questions. We will start the session with welcome remarks, followed by an introduction by the Singapore co-chair, presentation by the guest speaker, comments by the Latin American co-chair, and then we will end the session with a discussion time at the end. Those who have sent in your questions will be asked to speak then, and participants can also use the raise hand button to get the host to allow you to talk. This session will be recorded. By participating, we are presumed to have consented to the use of your audio and text comments in these recordings. May I now invite His Excellency Mr. Carlos Vasquez Corrales, Ambassador of Peru and Dean of the Group of Latin American and the Caribbean, GRULAC in Singapore, to make his welcome remarks. His Excellency, please.
Thank you very much. Professor Chong Yap Sen, Dean of the Yong Lu Ling School of Medicine at the National University of Singapore. Mr. Raja Kamal, Senior Director, Dean's Office. Dr. Marcel Hernandez, Professor Swain Chen, Professor Sofia Archuleta, 7 participant embassies of Argentina, Brazil, Colombia, Costa Rica, Chile, Mexico, Panama, and Peru, and participants, of course, of all these countries. It's an honor to chair my remarks in the inauguration of the first of the 4 video conferences that aim to foster the capacity building in the Latin American countries to deal with the COVID-19 pandemic. Certainly, solidarity among the nations is an essential value that must be practiced in difficult times like this one nowadays. I would like to thank and express the recognition of the government of Peru to the National University of Singapore through the Dean of the Yong Lu Ling School of Medicine, Professor Chong Yap Sen, for promoting the organization of the video conference and also to facilitate the exchange of information and relevant practices from the Singaporean perspective. I would also like to express my appreciation to all the experts from Singapore and Latin America that will participate in this initiative. I strongly believe the knowledge gained through the different sessions will foster your country's capabilities to better deal with the health crisis. Peru has been severely affected by the pandemic. So far, we have more than 890,000 cases, but fortunately, more than 800,000 persons have already recovered. The most difficult period was between June and August, when the cases rose dramatically, in spite of the great and extensive effort made by the government. Fortunately, in the last few weeks, the number of cases has decreased significantly, and I think we can draw some lessons from the Peruvian experience and share them with all of you. Today's session is related to community response towards the pandemic. Around the world, we have been witness that the number of cases of COVID-19 has overwhelmed the capacity of hospitals and health institutions. In some cases, states have to reinforce their health system with the support of their armed forces. Temporary hospitals had to be built to attend patients in critical state, for instance. Therefore, I think it will be productive to learn the interaction between the hospitals and people, as well as the strategies and actions carried out by the health system to engage the community. The successful case of Singapore is a key example of how to engage the community. The contention of the pandemic is highly important, considering COVID-19 is still among us. The threat of a second wave is a reality in other regions, and we all should be prepared. In diplomacy, the transmission of the real content of a message is important in order to build bridges among the nations. In this context, by actively participating in the video conference, more importantly, by sharing the new experiences, the experts from the different countries will be able to send positive messages to their communities and to send a strong sense of commitment. Thank you very much for your kind attention.
Thank you, Ambassador. Next, I would like to invite Dr. Swain Chen, Associate Professor of Medicine at the National University of Singapore, to begin today's dialogue.
Thank you, Hui Kun, and thank you to Ambassador Vasquez for helping us to open this series of webinars. As Hui Kun mentioned, we have a 4-week program that will cover Singapore's experience in multiple aspects of managing COVID-19, from the medical management of individual patients, going up to the importance of coordination at all levels, as noted just now by Ambassador Vasquez, and finally to current progress on vaccines and therapeutics. Today's opening webinar is about coordination at the local level. Coordination within a single hospital system and within the surrounding community. We're very excited to have Associate Professor Sofia Archuleta, Head of the Division of Infectious Diseases at the National University Hospital. As you will hear, she was a key leader in the overall response to COVID-19 that has swept through the world, including in Singapore, since the beginning of 2020.
Thank you so much. I am very excited to be with you all this morning, this afternoon, or this evening, depending on where you're logged in from. And I'd like to thank the organizers, including our dean and co-chairs, of course, for inviting me to give this presentation today. I hope I'm speaking as part of the audience that's with us today to other infectious diseases, hospital administrators, but also anybody else who's interested in the COVID response that we've had in Singapore so far, to share some of the challenges and the lessons learned that we experienced. This is roughly what I'll cover this morning. And of course, I'll be open to questions, and I'll give everybody my contact in the end so I can be approached with any further questions. I've been given the time limit of roughly 20 minutes, and it's going to be a bit tricky. I'll rush through quite a few things, but I will be focusing on the first 60 days of COVID-19, which was the lead up and the beginning of the surge period for us here in Singapore. I'll talk a little bit about the new normal, where we are right now, and what are some of the academic mission of our hospital and the reflections about this time. Who am I? So as Swain introduced me, I'm an infectious disease physician, an adult infectious disease physician. I know one of the co-chairs, Dr. Hernandez, is from pediatrics ID. We also have a pediatric ID division within the hospital here, but I will focus mainly on issues surrounding the surge in the adult population in our hospital. Where do I work? National University Hospital is Singapore's third largest. We have roughly 1,200 beds. We are a very busy clinical hospital, but we also have major roles in research and teaching as the major teaching hospital of the National University of Singapore Medical School. We house a full complement of tertiary and quaternary care services, which means we have, of course, pediatrics, obstetrics, gynecology, but also all the surgical specialties and subspecialties, including transplant and severely immunocompromised hosts, which is all to say there were busy academic infectious disease divisions of 13 clinical faculty. And also we have ID specialists in training. I bring that up to put the community which I represent in context, and to describe to you how we worked as a division, but also with the hospital and larger healthcare system leadership here in Singapore in the early days of the COVID response. So let's dive right in. This is a timeline. I know it's a bit small, but it looks, it may or may not look or represent what's happening in your jurisdictions currently or through the early days of the pandemic. But just to orient you, what happened in Singapore is, of course, we had some cases very early on after China. Then we had our surge period during March and April. Then we had our version of the lockdown, which was called the circuit breaker, from early April to early June to control follow essentially the surge in cases. And since June, we're slowly engaged in a phased reopening of services. And we're currently in what we're calling phase 2B, that allows for that has in fact gotten control of community spread. So we're seeing essentially an average of 0 to 1 cases per day, and the majority of cases that we see are imported, but are actually picked up while people are in quarantine when they enter Singapore. So what did it look like for us in the very early stages? There was quite a bit of soul searching into our division strategy and how we work with leadership at all levels. So of course, as we know, when China sneezes, Singapore and the rest of the world catches coronavirus. We anticipated cases very early on. There was, of course, there are and continue to be close ties between Singapore and China due to travel and other links. And the Lunar New Year was coming up on January 25th. So this was not going to be a surprise to any of us. And as a country that experienced SARS back in 2003 and had quite a bit of expertise brought about as a result of that experience, our ID leadership, hospital leadership met very early on January 5th to activate our emergency planning and command center. So for the division ourselves, we had to reorganize our operational structure to better meet anticipated needs. So we did this by taking a look at our individual strengths and interests and completely reorganizing our roles, our responsibilities. This is just to give you an idea of the broad categories of roles that we either already had in existence, for example, division chief or head, which is myself, a clinical director, an infection prevention director, an epidemiology director. But all the other roles that you see listed here were either created or reshaped for the purposes of the pandemic response, with responsibilities that had to do with the various portfolios and the reporting lines that we had set up in order to better meet the demands of COVID. So ultimately, it came very close to being that every faculty member in the division had to own a portfolio in order to make us nimble and to be able to respond to the needs. For example, research relating to COVID-19 or reshaping our training of our infectious diseases fellows, again, in the context of COVID-19, had to be taken on as discrete portfolios. What was our strategy? Our aim was very simple: protect our patients and protect our staff. We had a 4-0 aim, and that meant 0 patient-to-patient transmission, patient to staff, staff to patient, and staff to staff. And I'm pleased to say that our success in all 4 of the zeros remains 0 cumulatively since the early days of the pandemic. So that is something we're extremely proud of. In this context, we also did not want to forget that we didn't only have COVID-19 patients, but we also continue to have very complex patients requiring our care, and our usual services had to be preserved, both within infectious diseases and allowing, of course, our colleagues in the hospital, our oncologists, our surgeons to be able to deliver the care that our patients deserved. Another strategy was, of course, to enhance screening, surveillance, and isolation of suspected cases. I think, as you may know, Singapore's approach is to isolate every case, regardless of symptoms, and we are still doing that. This is either done in the hospital setting or, as the epidemic rolled on, it occurred in the community setting as well. So this is in line with our national approach, and the same occurred at the hospital. We also did, it was part of our job to ensure that our required resources and manpower were there for current needs and also for stepwise scale up as the surge came on. So this included things like creating, of course, PPE guidelines, additional training for all our hospital staff. We had a principle of team segregation between people or staff who were caring for COVID-19 patients or suspects versus caring for other types of patients. And that was something that was learned from SARS as well, as an example. What does it look like once the strategy is set? Then, of course, all hell breaks loose, and it's time to ramp up. But with preparedness, of course, the idea is to do it in a stepwise and controlled fashion, and to keep the healthcare system and our hospital from being overwhelmed. This very much depended on having the lab testing capabilities for diagnosis of COVID-19, and not only to have the capability in-house, but to have rapid turnaround times that allowed us to make timely decisions about further isolation of patients and meeting their needs. So this is a timeline that goes from the beginning of February towards the end of March, and shows the stepwise number of patients who were coming in as suspects into the hospital once we implemented our screening protocol. So currently at our hospital and across Singapore, any patient that comes meeting criteria for an acute respiratory infection, or ARI, would be isolated and tested for COVID-19. Of course, they might be higher or lower risk depending on prevailing epidemiology. But starting February 5th, so the day after we implemented our hospital-wide isolation policy, we were able to run the PCR test for SARS-CoV-2 in-house. Our lab responded beautifully to the pressures, and all credit to the entire staff for being able to keep this up all these months. And building that capability has allowed us to turn around our isolation beds, as you will see in the next step, in the next slide here. So our peacetime capabilities for isolation is we have 42 negative pressure rooms across 2 wards. So if you just take a look at the top slide as an example, we had to plan ahead for the surge in isolation capacity that was required, and how those needs would be met. So there's a plan in place in the hospital, again, from the days of SARS, and has been looked at during regular exercises for pandemic or outbreak preparedness. And the plan was put into place with tweaks along the way, of course, but to increase the capacity of isolation rooms. So from 2 wards, we went up to 5 pandemic wards, more than double our capacity, almost 100 isolation beds during this time. And again, because of the availability of the PCR testing, we were able to turn around those beds very quickly. So once somebody came in, they were tested, the clinical evaluation was done, and usually with 2 PCR tests done 24 hours apart, we were either confirm the infection and keep the patient, of course, in isolation, or move them out of isolation and then admit somebody else. And on the second part of the graph, what you see is admissions versus discharges. So in order to not overwhelm our capacity, we had to discharge or transfer people out as quickly as they came in, so we could maintain the flow of patients. So in the early days, of course, you test a lot of people and you only pick up a few cases, but then ultimately, if cases in the community go up, the proportion of your COVID patients relative to your COVID suspects goes up. So then the economies of scale come in, and it's no longer, as a hospital, it was no longer feasible for us to keep COVID patients in single isolation rooms, and we opened cohort wards. So our isolation room might look something like this. This is from our negative pressure ward, but our cohort wards will look like this. So during the peak of the surge period, we had 3 wards that usually are 6 to 8 bedded cubicles with natural ventilation, and all COVID patients were cared for here. This allowed us, this also did have some benefits for the staff, of course, because we were able to free up our isolation rooms, but for the patients as well. A bit more social interaction when you share with other people who are going through similar experience with COVID-19 as you are, and it allowed us to keep families together as well. So we did have couples, parents, children together in the cohort wards. So how does this, so it's not only an issue, of course, of hardware, but also of software. So the people, there are, as I told you, 13 infectious disease physicians, and the number of patients, of course, was too many for us to handle. We are, as an academic division, cited within a department of medicine and a larger healthcare system. So what we planned on early on is as the number of wards was being scaled up, the number of teams of both faculty and also resident our trainee physicians, there was a roster that had an incremental call up of what we term pandemic teams. So colleagues in the Department of Medicine, regardless of specialty, also helped man the pandemic wards. And the way that we did that in order to empower them to do this, of course, safely and to feel comfortable doing it, is they were augmented by an ID physician. So even if there wasn't somebody, an ID physician caring for those patients, there was what we called augmentation. So they were able to be buddied up with an infectious diseases physician to make this happen. So it allowed us to multiply our numbers significantly to be able to meet the demand. Another thing that was done very early on and has been modulated up or down, depending on where we are in terms of the manpower demands. It was a reduction in, of course, our elective surgery, for example, or an elective caseload. Anything that was non-urgent was deferred, including outpatient appointments. To give you an idea, the Department of Medicine as a whole dropped our outpatient visits by 30% or more, and within the Division of Infectious Diseases, we were down to about 30% of our usual clinical outpatient caseloads because those appointments had to be diverted. Non-clinical workload, of course, as well. So non-COVID research, teaching that could be deferred was deferred as well during this time to free up clinical manpower. In this entire process, as new people were trained, and of course, all of us were learning at the same time about a new condition, communication and feedback channels were paramount, managing the anxieties on the ground in addition to the clinical and operational needs. Very, very much hinged on communication, the feedback channels, as I mentioned, and building trust with all the stakeholders. So having all the existing relationships between an infectious disease or infection prevention team and the rest of the hospital, and building on that throughout was absolutely critical. I put this here just because it's an infographic that I'm extremely proud of, that was put up by our larger healthcare system, the NUHS, or National University Health System. And just to remind that everyone that even though Singapore is an island, we in the ID community are not an island. We work within a regional ecosystem. By a regional here, I mean we're responsible as the academic health hospital for the western part of Singapore. We work with partner hospitals, primary clinics, community hospitals, of course, and there was close coordination at all those levels that took place, comparing experiences, comparing what worked, what didn't work, and that was critical throughout. National coordination, the ID community had a voice at the national level. So from the, there's been a whole of government approach that was taken in Singapore with close communication between the policymakers, the health system decision makers, and the individual physicians on the ground. And that also has been paramount to the success, I would say, at this phase of the pandemic. The ID community has been represented throughout all those I suppose, links in the chain of command, and within the hospitals in Singapore, we established channels. So even things like informal WhatsApp chats that included all of the ID division heads across Singapore in order for us, again, to share lessons, to compare notes, even to transfer patients and families between our hospitals was coordinated very closely so we could deliver care effectively and safely. International, I think we've talked a lot about COVID being something that will be defeated by global solidarity. It's our shared responsibility. And from the early days, we've taken this very seriously, learning as much as we can from colleagues abroad, and also sharing our early lessons by doing a lot of Zooms in the early days with hospitals in the US, for example, Australia, as Singapore was hit first, while the other countries were still bracing. And I am, is one of the reasons I'm so pleased to be part of this webinar, to continue this type of sharing with you as well. I think, as anyone who has had this type of job will know, is that when there's a crisis, and certainly when there's an outbreak, then there is an outbreak within the outbreak. What do I mean by this? Well, there is an outbreak of workflows for sure. So again, this is an example from one of our recent publications of some of the elements that were part of our response. Developing workflows, becoming very adept at making PowerPoint slideshows with algorithms and arrows that carry, for example, a patient's journey safely from screening, triage, isolation, all the way through to discharge in the adult and emergency departments, adult and children emergency department, an ambulatory setting, inpatient setting, surgical workflows, women delivering babies workflows, staff safety and management. All these things have to be thought about and either completely invented from scratch or adapted from the previous pandemic or outbreak response playbook that the hospital or your healthcare system may have in place, and really need to be looked out throughout as the epidemic goes on. And it is literally a full-time job. An outbreak of meetings of communications. We joke with colleagues that at some point when this is all over, we will do an epi curve of our email inboxes. I'm not sure I want to do that. I have a feeling I might have flashbacks if that happens. But I think you all get what I mean. The number of phone calls, WhatsApp messages, Zoom meetings that occur is really tremendous. And it's important for people filling these roles to be cognizant and to plan for this. Also, in terms of those feedback channels that we mentioned, how do people reach you to either have, when they have clinical questions or workflow related questions, or just to allay anxiety? ID folks need to be contactable and need to give good and valid information. So we did that at our hospital by setting up WhatsApp channels. So all the pandemic teams that I mentioned previously were connected using group WhatsApp channels. We also had a 24-hour hotline until quite recently, until the 7th of September, when we decommissioned it, a 24-hour hotline where people could reach us on their mobile number. The other outbreak that contributes to what I'd call cognitive overload that can occur during this period is, as we all know, with a new disease. Of course, it's great that research is able to occur in real time and we learn together about this virus, but it's something to be mindful of. We all know there's been a tremendous amount of information and misinformation that has been published. So part of our job as ID physicians and ID experts is to sort that out for ourselves and for our colleagues. So if you haven't had a chance to think about who siphons that information for you, I would recommend that you do so. It can be the job of the ID trainees, for example, who can do journal clubs and try to do succinct presentations for the rest of the division or the hospital to help in these situations. We found that worked very well and they enjoyed it. In terms of where we are now, so as mentioned, we went through a phase, the circuit breaker for 2 months in April and June, and that did work quite effectively to limit community transmission. And also what we found occurred in the situation in Singapore, and where the majority of the cases occurred was in congregate settings that were our foreign worker dormitories. So a little bit about that. As everyone has heard by now, this virus has exposed vulnerabilities in all our communities. And in Singapore, that was the foreign worker dormitories. In other places, it has been in other types of congregate or public housing, such as occurred in Melbourne, but also places like meat packing packing factories or plants in Europe, for example. So it is a virus that exploits and exposes vulnerabilities. So when a surge occurs, it could be because of one of these vulnerabilities. As mentioned in the case of Singapore, it was in our dormitories. And when that happened for us here, we had to think about how to further, number one, increase capacity. So creating those additional cohort COVID wards and creating extra capacity in our emergency department, for example, and workflows, how to meet that demand. It may also involve, and as His Excellency pointed out earlier in his introduction, it might involve setting up field hospitals or other types of ways to deliver care outside the walls of a hospital like NUHs. So setting up medical posts in the dormitories, setting up community isolation facilities for well patients, and then being able to focus on identify those who are, for example, older, have comorbidities or are sicker, and focus on getting them into the acute hospital while caring for the rest safely in community facilities was one of the ways that the surge was responded to here in Singapore. And thinking about, of course, very patient-centric response. So if a particular segment of the population has been disproportionately affected, think about the tools and provide the resources to meet patient needs within that community. So having resources, for example, in the language of those patients and making sure that it's culturally appropriate, or having other types of needs met, such as SIM cards, for example, so that they can call back home in the case of the migrant workers. So where are we now? As mentioned, since the end of the circuit breaker, we're slowly resuming opening up services after that peak in April and May. It's a bit small down here, but this is where we were as of 2 days ago. Our total number of cases is about 60,000 per capita. That's actually one of the highest in Asia. But we're very proud that on this bottom right, you see the number of mortalities is only 28. So even though it's one of the highest case rates per capita, we actually have one of the lowest case fatalities rates in the world. And that is, my apologies for the doorbell. I am actually in quarantine as we speak because I traveled back from Europe recently. So we are back to perhaps what we are calling business as usual. The hospitals have stood down a lot of the services and a lot of the COVID specific wards. The picture that you see on the bottom right from August is the day that we closed our last cohort pandemic ward. So we are now back to treating COVID patients in single isolation rooms because we have such few cases these days. And I know I am bound to get some questions about perhaps, or hopefully I'll get some questions about our success in managing the sick patients, but I will leave that for the speaker in 2 weeks from now. The next speaker, who's my colleague, Dr. Samani, will speak about clinical management. Okay, great. I'm getting just to the very last portion of my slides, where I will talk a little bit about the academic mission of the hospital, which cannot be forgotten at this time. And again, as a teaching hospital, that was very important to us, something for you to reflect on. Myself, I'm a zombie enthusiast, so my favorite outbreak movie is World War Z. As with all forms of outbreak, education and providing the right information is very important. So in addition to our academic mission, we felt very strongly that education had to engage the media and lay people. So we did embrace all forms of media, including webinars, newspapers, TV, radio, you name it, and even cartoon strips. In the case of our future ID specialists and our future internists, we worked very closely with the educational program directors to reshape the training program so that they don't lose sight of not just how to respond to a pandemic and learning about COVID itself, but to make sure that they meet their other training needs. And this is from a couple of publications that we made that I'll let you guys read through at the end when I give out the references. Finally, to reflect on a silver lining, we had a situation where infectious diseases may not be the most oversubscribed specialty, but we find, and we internationally, there's a shortage of infectious diseases physicians, but we find that trainees and medical students are expressing more interest these days. So I'll take that as a COVID silver lining, and I hope there's more of them in the future or at the end of this very difficult time. And I'll end on this as part of my as my topic included community response. I talked quite a bit about the ID community response, but this is to remind us all that we couldn't have done it without the support of not only the hospital and healthcare community, but also the community at large. In Singapore, there were days where we couldn't go anywhere in the hospital without being offered either flowers, cupcakes, something to eat, treats, cards poured in from patients, from community organizations, even pastry chefs who felt the need to send some of their creations in for us. And again, all to say that we were and continue to be in it together, and it wouldn't have been possible without these people. Finally, I shared a kind of a whirlwind there during this time. It was very important for us, as mentioned, to share our experience. And these are some of the references I shared. In the chat box, our MC is adding for you links to some of the references. They're freely downloadable, so do utilize them as you would like. And you also find here my email. I'm happy to be contacted by colleagues anywhere in the world, but for the purposes of this seminar, I welcome any questions or contacts with Latin America. Happy to chat over any of the channels that are available to us in this brave new world of Zoom. And I'll stop here. I will hand it over to Swain, and I will stop my remote control. Thank you so much. Over to you, Swain.
Thank you very much, Sophia, for an outstanding overview of the National University Hospital's response, taking us through some of the key challenges in manpower, bed space, communication, coordination, and leadership that are certainly common to all hospital systems. So as mentioned, we will have a question and answer session, and I'd like to remind everyone and invite everyone to submit questions at any time through the Q&A function on Zoom. But before we get to those questions, I'd like to first hand it over to my co-chair for this session, Dr. Marcela Hernandez, for an overview from the Costa Rican perspective. Marcela?
Thank you, Swain, and thank you very much for the opportunity to co-chair this webinar. What I want to do in 5 minutes is just a quick summary of Costa Rica's response to COVID-19. It's all been driven by our social security system, CAJA, and the Ministry of Health. Our surge was a bit later than the rest of the world. We started with our surge in July, and I think we are still in the peak because we still have a lot of cases. We have about 100,000 cases with 1,000 deaths. Of those, we usually have 500 plus hospitalizations. And of that big number, 8,000 has been pediatric population. So what we initially did was follow the world. We followed the world because our search was a bit later. We did a lot of actions as the rest of the world did, closing travels and a lot of increasing bed numbers, looking for more healthcare personnel, and all of those tragedies of closing elective clinics, stopping elective surgery. We did all that, and we focused mainly at the beginning to contain, to identify, to isolate, and do contact tracing. But now throughout the months, we've had to do different strategies and have a lot of interinstitutional collaboration. Next. Some important interinstitutional collaboration that we've had is the treating active patients with convalescent plasma from recovered patients, the production of purified antibodies from recovered patients, as well as purified heterologous antibodies. Next. And then the intervention strategies have been, moving forward to give more first level attention so that we can get to that vulnerable population, the susceptible population that are prone for COVID-19 complications. And with this strategy, the aim is to decrease the impact in the hospitalization rate and the number of patients in the ICU, and as well as the mortality rate, because then we can get early on to the development of complications to the most vulnerable population with risk factors, and advising them, educating them so that they can limit transmission once there's a large amount of cases around in their locality. So we do have technology systems in place with a lot of technology support where we can have projections by province, by district, so that at a local level, they can be prepared to see what might happen in the next few months on their locality, so that they could do close surveillance next. So they can do close surveillance, and then the teams can coordinate and move towards the districts or the other provinces, localities that are increasing in number of cases per epidemiological week. Costa Rica is a very small, very, very small country in Latin America. We have 4.5 million population, and so it's easy to move from one place to another in the country and mobilize helping teams so that they can go over to those vulnerable populations that are most at risk to give close follow-up. So next, please. So we do have a program that we can give follow-up for the patients that aren't hospitalized, that are in their houses in quarantine, so that we can catch their symptoms at some point and identify the most susceptible hosts, so that once we identify the most susceptible people, if you could. So once we identify our susceptible population, it's not only the healthcare interventions, there's also a coordination for social services and coordinate socioeconomic health and identify their chronic comorbidity so that they get treated on a good timing, and give all the education and supervision so that they can limit their exposure to the virus. So very early on, as we followed the world and all the strategies, our national liquor store helped a lot by increasing the production of hand rub and distributing ethanol, because we produce our own ethanol, and distributing ethanol to small companies so that they could also produce more hand rubs, and then the whole community, not only healthcare system, could have access to good hand hygiene. The Costa Rica's office post also helped in a lot, because they distributed medications to the house of every patient, and mostly the patients with chronic diseases, because our clinics, they did close, and we were working at the beginning just a lot of the emergencies. So those are intercollaborative strategies that helped a lot, and some of them are still ongoing. And of course, very important for the health sector to educate, so that throughout communication and press, TV, radio, and social media, like the rest of the world, that we could get the education and the information for the community. There was a lot of social help, throughout the communities. We did have a lot of donations for people who were losing their jobs, as well as for people in vulnerable communities that were in quarantine. So there was a lot of movement around, so that they could support not only from a health point of view, but also taking care of the families with very poor resources, that they have food. And there were other responses. The Ministry of Labor did this protect bonus with economic bonuses. The banks extended and did some adaptations to bank loans. And of course, there was adapting commercial activities, a lot of takeout and express services, and restaurants closed, as in the rest of the world, and different modalities for working opportunities. We're all learning this now. We're all Zoom experts, and learning system adaptations. And of course, and until now, it has been an issue on the personal protective equipment, So there has been a lot of elaboration, in-house elaboration and donations of PPE for healthcare as well. So this is a little bit of what I wanted to share, and I want to get back to you, Swain. Thank you very much.
Thank you, Marcela, for these insights into how interventions were prioritized in different communities and patient populations in the ongoing COVID-19 response in Costa Rica. At this time, we'd like to open the floor for questions. So again, you may type questions into the Q&A box at the bottom of the screen, typically on the bottom of your Zoom screen, or you can also just raise your hand in the participants list and we'll call on you to ask your question directly to either Associate Professor Sofia Archuleta or Dr. Marcela Hernandez. So at this time, it looks like we don't have any questions yet. So while you guys are thinking, I'm going to take the chair's prerogative and ask the first question. And this is for Sofia. So you mentioned that NUH is one of the big hospital networks that is responsible for the western part of Singapore. And you also mentioned how there was some coordination between the other hospital networks. Could you talk a little bit more about that? For example, what were the processes? How did you guys actually coordinate between the different hospital systems? Were there some things that worked better or worse that you might be able to share that could be useful for other countries?
Absolutely. Good question. With a lot of meetings, a lot of, no, I'm just kidding, different modes of communication. So having, I'll start with within our regional health system. So for our network of hospitals and other practices, we set up, so the organizational structure of the healthcare system including all the relevant stakeholders, so infectious diseases, infection prevention, operations people, we're all adapted to COVID-19 so that the operations command center existed at each hospital level, but also overall at the NUHS or health system level. And we had meetings during the peak of the pandemic during, all the way up to probably June, July. We were meeting twice a week, initially face-to-face, then over Zoom, again, having built communication channels, including like secure messaging, WhatsApp messaging, other types of communication. So all the stakeholders would have a platform to engage around these issues, and the organizational structure of the institutions together allowed for that and enabled that. As infectious diseases folks, we would consult on the expertise and work with the operations people to come up with whatever workflow, policy, circular, whatever was needed to respond to the needs of the moment. But the overarching strategy, as I mentioned, was set from the beginning, from the very top of our organization structure, and that was to focus on protecting our patients, protecting our staff, and setting the goal of the 4 zeros. At the national level and working with the other hospitals, very collegiate. That's very important during such difficult times, I would say. So again, having those open communication channels worked very well. So we were able to get a hold of, the ID, HOD at the other hospital at any time of day or night quite readily, and be able to work through issues together. Our Ministry of Health people also highly available to us about questions, about sending feedback about what was working, what wasn't working during different periods of the surge, being able to give advice on PPE policies, for example, that were developed nationally but would need to be tweaked, and ensuring that we compared notes along the way. For us in Singapore, of course, we're a small country, so anything that one of the hospitals is doing that perhaps the other isn't, of course, it's important to adapt to your own individual needs. We're not all the same. And of course, a tertiary hospital is not the same as a primary care clinic, but having general evidence-based guidelines, especially in the beginning where there wasn't much evidence about the virus, could be tricky. And then how do you adapt that evidence to the individual settings in a way that makes sense, that's practical, that's enforceable, was a big challenge. As we went along, it was easier to tweak things with the evidence building, with the trust building, as of course we achieved zero transmission, and we didn't see the transmission in the healthcare settings here that was feared or could have occurred, but didn't. I think we were able to build on that trust and work within the hospital setting, and of course engage the community in ways that we may not have been able to otherwise.
Perfect. Sophia, I have a few questions for you, but I'm just going to ask one and then give opportunity if anybody else has a question. Well, what I wanted to ask you was from the medical students, what did you do with the medical students? Because at the beginning it was, trying to decrease the risk of people getting exposed to the virus in the hospital care setting.
Yeah.
So the medical students, microbiology students, like, what was the role within the healthcare, or were they sent home and just virtual lessons,
That's
or
right.
what tasks, or they just were able to go and keep studying from afar and not getting the experience, because that's like a big concern, having the medical students miss out on the experience to protect them. Like, what was your experience? What did you do?
A bit of a mix. And again, it was a kind of a phased approach during the peak of the surge, when it was all hands on deck, and there may not have been adequate time to supervise medical students. They were in fact sent home and engaged in remote learning in order to ensure their safety. Of course, as we all know, there's a continuum of medical education. So the more senior people in the continuum, so our residents and our fellows were in fact in the front lines together with the rest of us, and we were all learning together. As we went on, now the medical students are coming back for medical postings, of course. So setting up the PPE and infection prevention training, so both lecture-based and then doing hands-on sessions and getting that in place for everyone, from the very senior people in the hospital, then all the way down to our medical students, and making sure they're protected is an important part throughout, and making sure that, as you said, that the medical students are engaged but also safe is a fine line. So there was a period where they were home, meaning they weren't allowed into the hospital for their clinical postings, but were learning remotely. And then slowly they are now allowed back in the hospital. And we do still have some COVID, so they're learning from the experience. In terms of, I think it is important for the next generation, not just to get the clinical experience, which I have a feeling they'll continue to see COVID, hopefully in a slow trickle and not in big surge or waves of the outbreak as time goes on, but also learning as appropriate about the operational, the administrative aspects of responding to an outbreak has been important as well. So setting up sessions like this, where they learn about those aspects for the future, has been a focus for us as well.
All right, thank you. We have another question that has come in through the question and answer, the Q&A box, and this is for Dr. Hernandez. So David Allen, would you like to unmute your microphone and ask directly?
Thank you, Swain. Yes, I'm just curious as to, with the information about the pandemic spreading and it not arriving in Costa Rica until mid-year, in light of the PPE shortage worldwide, was Costa Rica able to stockpile in advance, or did Costa Rica need to find workarounds like many countries in the world for shortages? Thanks. Over.
Yes, thank you for your question. At the beginning, we were able to stockpile a little, and we did receive important donations besides what we were purchasing. But we've been having the same problems as the rest of the world. Now, currently, we don't have a stockpile. We're basically, what we receive, it's what's distributed throughout the healthcare system. But the stockpile did help at the beginning of the surge, of course. And as of today, like, we haven't been down to zero, but we're close. Like it's a very fine line. As soon as the PPE comes in, they get distributed, and we're like just on time every time that it's close to shortage. I don't know if that answers your question. Yes, but yes, we are having a lot of troubles getting PPE, mostly respirators. Right now, our challenge is the respirators. Mm-hmm.
Yeah, I think that's a common thing that's happening all over the world. Certainly, that's been something we've been dealing with in Singapore as well. So let's see, I want to ask one last question, since we don't seem to have any other raised hands or questions in the Q&A. So this is for Sophia. You showed a touching picture of a couple that was sitting 2 meters apart in the, in sort of opposite beds. And, that really puts a human face on, what's been something that requires a lot of international and coordination among different communities. So do you have any personal moments you'd like to share to sort of put a more human face on what's been happening in the last 6 months of your experience? I know you talked a lot about kind of the operational concerns. Would you like to sort of share any personal experiences from the last 6 months?
It sure hasn't been easy on anyone, but especially hasn't been easy for patients and their families who have been affected for COVID-19. I think the saddest or hardest part of the patient experience that we've witnessed has been the experience of being in isolation, being separated from their loved ones, especially if they're going through critical illness. No matter how many times you do a Zoom or a FaceTime or a video call with your loved one, it's just not the same. So that's been heartbreaking to see people see our patients experience that. The other aspect has been perhaps not so much now, but certainly in the early days, a lot of stigma has not a new thing for infectious diseases to face stigma when you're diagnosed with an infectious disease. That certainly was the case with COVID, and then this whole concept of who gave it to whom, or when did you have symptoms? Is it possible that you gave it to me? So we had patients who were in isolation in the hospital, and then you'd see they'd get calls or they'd get chats from their friends, and normally it would be to check how the person is doing, right, or to wish you well, but there would be like this undertone of, when did you have symptoms, right? And there was this idea that the person was being accused of then perhaps passing on COVID to a friend or a relative, and that was really hard to see. It's a lot to go through, especially I think with a new infectious disease. Yeah. The bright spots were, so the couple that you saw in that picture was on the cohort ward. So there were times when we were still in the isolation phase in the single rooms. We'd have couples or families where they would each take up one room. So the husband and wife could be separated. They wouldn't be able to see each other. But when we opened up the cohort wards, then they were able to hang out together. So that was kind of nice. And there was certainly within the parent and child pairs or larger family units, there was a little community on the cohort wards that occurred. And so that was nice to see the breakup, the breakdown of those isolation barriers, and they were able to share that experience. I hope it helped. I'm told by patients that it helped, and I hope that's indeed the case.
Okay. Well, thank you for sharing those, Sophia. And I think really this is from a doctor's point of view, right? Really why we're doing all this stuff. That sort of patient perspective is something that we keep front and center in our minds. And it's a perfect segue for me to talk about what will be the next episode of this webinar series, which is going to be about individual patient management. So I'd like to close this at this point. First, I'd like to extend a warm thank you once again to His Excellency Ambassador Vasquez and all the other country representatives that have participated. and to our Dean, Chong Yap-seng, and Mr. Raja Kamal for establishing and supporting this webinar series. I'd also like to thank our guest speaker today, Associate Professor Sofia Archuleta, and my co-chair, Dr. Marcela Hernandez, for the insights and discussion today. Finally, a very warm thank you to all of you who signed on, managing the time zones with Asia, and we look forward to seeing you again in the next 3 webinars, the first one coming up in 2 weeks from now at the same time on Friday morning.